Welcome everyone to whoever is joining me in person here or virtually in this not so nice weather. Again, welcome. I'm Dr. Audrey Adji. I'm hosting this seminar in person from Victor Chang Cardiac Research Institute. I'm a postdoctoral scientist here at Victor Chang and also a research fellow at St. Vincent's Hospital, Sydney. And we acknowledge the traditional owners, the Gadigal and Buramatugul people of the Eora Nation and the Daruk Nation, whose culture and customs have nurtured and continue to nurture the land since men and women awoke for the great dream. We honor the presence of these ancestors who reside in the imagination of this land and whose irrepressible spirituality flows through all creation. We also acknowledge the people of Wajik Noongar, to whoever joining from the Western Australia. For today's seminar, we will have two presenters, Dr. Christie from St. Vincent's, Sydney, and Dr. Bola Fasugba from Australian Catholic University. Each presenter will have 15 minutes to go through their slides, then we'll have 10 minutes question at the end of each presenter. I'll keep an eye on the time, and for you who are interested in asking question, you can do that by raising your hands in the Zoom function, or you can just, or alternatively, you can also put your question in the chat. Allow me to welcome the first presenter, who's Dr. Lauren Christie. Lauren is an occupational therapist, clinician researcher, and the senior implementation science research fellow, Allied Health for St. Vincent's Health Network, Sydney. Her PhD studies focus on clinicians' behavior change in stroke and traumatic brain injury rehabilitation using implementation science method. Lauren is currently running a stroke rehabilitation training workshop internationally with a focus on implementation and sustainability of evidence-based intervention. We welcome Lauren, and please share your screen.
Thank you, Audrey. You can see that clearly? Great, thank you. Thank you very much for the opportunity to present to you today. I'd also like to acknowledge that I'm presenting today from the lands of the Gweagal people of the Darawal Nation and pay my respects to elders past, present and emerging. As Audrey has mentioned, I am the Senior Research Fellow for Allied Health at St. Vincent's Health Network in Sydney, but today I'll be presenting on a program of research that formed a component of my PhD and was conducted as a collaborative research program between South Western Sydney Local Health District, the University of Sydney and the Ingham Institute of Applied Medical Research, supported by a New South Wales Health Translational Research Grant. And I'll then briefly discuss some new projects we have underway at St. Vincent's that expand on this work. So to provide you with some background, constraint-induced movement therapy, or CIMT, is an upper limb intervention that's been demonstrated to be very effective for arm recovery after stroke. CIMT involves placing a mitt or restraint on the person's non-affected upper limb and the person completing a high-intensity task-specific rehabilitation program using their affected arm. A 2015 systematic review of CIMT intervention, including 51 randomized controlled trials, was published in The Lancet and found CIMT to be an effective intervention for upper limb recovery after stroke, reporting an effect size of 0.2 to 0.8 for motor function of the arm, improved amount of arm and hand movement in daily life, as well as improved function in activities of daily living. Constraint-induced movement therapy is our only upper limb intervention that's listed as a strong recommendation within our National Living Guidelines for Stroke Management here in Australia for improving arm function. And more recently, the guidelines have been updated with an additional recommendation that demonstrates that CIMT not only improves arm function, but is also an effective intervention for improving strength after stroke in the affected upper limb. However, what we know from national audits of our stroke rehabilitation services here in Australia is that less than 11% of eligible stroke survivors receive CIMT during their rehabilitation. There have been a range of studies internationally that have explored the barriers to CIMT implementation. Across those studies, common barriers have included therapist-related barriers such as lack of knowledge and skills in delivering the intervention, patient-related barriers such as their physical suitability for a program, and resource-related barriers such as lack of time. As CIMT is an intensive program requiring people to complete at least 2 hours of active therapy per day for at least 2 weeks. But there's been limited research to date that has explored ways of tackling those barriers. So the aim of the Active Arm study was to investigate whether supporting clinicians via an implementation package could support them to change their behaviour and increase the number of CIMT programs that were delivered over 2 years across Southwestern Sydney Local Health District. This was a mixed methods implementation study that had multiple research questions, and we used the RE-AIM framework to guide the evaluation of this program of research. However, for the purposes of today's presentation, I'm going to focus on the primary research question, so whether rehabilitation teams deliver more CIMT programs after receiving a CIMT implementation package, and also around efficacy. So whether people who receive CIMT achieve upper limb outcomes consistent with the published literature. So 2 key research methods were used within the Active Arm study. Firstly, medical record audits and feedback, and secondly, qualitative focus group interviews. We conducted three monthly baseline audits at each of the 9 participating services to identify the proportion of people who were eligible for, offered, and delivered a CIMT program. Once we completed those baseline audits, we then conducted a series of focus group interviews with each of the 9 participating services, as well as occupational therapy and physiotherapy managers, to identify what the barriers and enablers were to delivering CIMT within rehabilitation settings in a public health context. We then developed and delivered the Active Arm Behaviour Change Intervention, a multimodal implementation package to help support clinicians to change their behaviour. Following delivery of the package, we then repeated audit and feedback cycles every 3 months for an 18-month period to evaluate changes in practice across the 9 participating services. During that 18-month period, patients who received a CIMT program within usual care were invited to share their program and outcome data with the research team. Following the 18-month intervention period, we then conducted post-intervention focus groups to explore patient recruitment methods, modifications and adaptations made to CIMT to meet local needs, and any ongoing barriers and enablers that may affect CIMT implementation sustainability. 6 months after withdrawal of our implementation support, we then completed one final round of audits to evaluate whether practice change had been sustained after withdrawal of the implementation support. In relation to our baseline audits, we completed baseline retrospective file audits at 3 time points and found that whilst around 1/3 of stroke survivors were eligible for CIMT, less than 2% were offered and delivered a CIMT program. Those who had been delivered a CIMT program, also a more detailed review of their notes indicated that those programs weren't delivered with fidelity, with key components of the intervention, including the transfer package and grading of activities to increase the level of challenge missing from those therapy programs. We then conducted a total of 9 focus group interviews and 4 individual interviews with occupational therapists, physiotherapists, allied health assistants, and therapy managers from the 9 study teams in Southwestern Sydney Local Health District. In terms of barriers to CIMT implementation, there were 3 key domains identified. lack of knowledge. So therapists lacked knowledge of the components of a CIMT program. They often reported knowing about CIMT, but not knowing how to deliver a program. Linked with that lack of knowledge was a lack of confidence in their ability to then deliver a CIMT program. And as a consequence of that, they simply didn't offer it in their practice. Finally, consistent with other previous research in the area, clinicians highlighted barriers relating to inadequate resources, including lack of staff, lack of time, and in some instances, limited physical resources to be able to deliver a CIMT program. In terms of enablers to providing CIMT, there were 6 key domains identified. First was that clinicians interviewed believed that CIMT should be part of their professional role in delivering evidence-based rehabilitation. They were also concerned about the negative consequences of not delivering CIMT, both in terms of the impact on patient outcomes potentially, as well as their team's compliance with the National Stroke Guidelines. They were also optimistic that they would be able to deliver CIMT once they had received some further training, and that they could use their existing upper limb therapy skills in task analysis and retraining to structure and run a program once they'd received some further guidance. Importantly, they also highlighted the importance of clinicians working collaboratively and organisational support for the change in practice, and that they would need to involve the broader multidisciplinary team to support implementing CIMT. So the findings from those interviews were then used to inform the development of a theoretically informed CIMT implementation package to target therapist behaviour change and support clinicians to increase their use of CIMT in practice. The implementation package includes the use of audit and feedback cycles every 3 months to provide teams with updates on the proportion of people who are offered, eligible for and delivered a CIMT program during their admission. We provided a series of 2-day CIMT training workshops to increase therapists' knowledge and skills. A monthly community of practice was held, with each team nominating at least 1, but usually 2 local CIMT champions within their team, who then dialed into that teleconference and were provided with ongoing support, coaching, positive reinforcement, and a really useful forum for joint problem solving and sharing of any ongoing barriers to getting CIMT programs up and running at their site. Each team were also provided with some posters to act as reminders in 2 ways. One poster was targeted at therapists and displayed in offices, encouraging them to consider CIMT as part of their treatment planning, and the other was targeted at stroke survivors and people with brain injury, encouraging them to ask their therapist about their suitability for a program. And finally, some drop-in face-to-face support was provided during each team's first CIMT program to assist with their skill and confidence development. This is now looking at the outcomes from our file audits that were completed over the course of the Active Arm project. So you can see from T1 to T3, we have our 3 baseline time points there, where you can see that it's less than 2% of eligible people who were offered a CIMT program. We then delivered our series of training workshops and commenced delivery of the implementation package, including the community of practice, in March 2017, and we saw an immediate improvement in the proportion of people who were offered a CIMT program, as demonstrated by those blue bars, and the proportion of people who were then delivered a program, which is represented by the lighter blue line there. You can see that change in practice continued to further improve up until the end of the 18-month implementation phase. We then withdrew our implementation support and measured again 6 months later, and we're very excited to see that this change in practice had been sustained. with around 60% of eligible people being offered a program and around 50% receiving a CIMT program at that final time point. So just to provide some context, within the broader implementation literature, a 15% change in practice is considered a positive outcome. So to have seen these changes in the proportion of eligible people who are offered and delivered a program, we're very excited to see those outcomes. On this slide, I'm just going to highlight to you some of the patient outcomes that were achieved by people who agreed to share their CIMT program and outcome data, who received a CIMT program during the intervention phase. You can see on the left there, we have our outcome measures, the action research arm test, a measure of arm function, the box and block test, which is a measure of dexterity, the Canadian Occupational Performance Measure performance and satisfaction scales, which look at occupations and activities of daily living, and the motor activity log, which records the amount of use and quality of movement within the affected arm. Now, across all of those outcomes from before to after a CIMT program, we saw statistically significant and clinically important improvements across all of the measures. And we then measured people again 1 month post completion of their CIMT program. And we're excited to see that once again, those improvements were sustained.
Sorry, Lauren, you've got 1 more minute to go.
Sure. Thanks, Audrey. So in terms of our implications and future research directions, you can see there that we addressed a very important evidence practice gap, but we did find that clinicians reported needing ongoing support for sustainability of CIMT programs. So looking at opportunities for booster training sessions, because it is a complex intervention, as well as the ongoing community of practice, and leadership support is required to help maintain those elements. We can't just set and forget. Also, that the use of interdisciplinary models help to support CIMT delivery. And so we've taken what we've learnt from Active Arm and are now looking at an implementation trial where we're looking at remote delivery of constraint-induced movement therapy across 3 sites in Sydney: St Joseph's Hospital, St Vincent's Hospital and Liverpool Hospital. And the study's also being replicated by colleagues in Chile to evaluate whether we can successfully implement CIMT programs delivered via telehealth. Thanks very much, Audrey.
Thank you, Lauren. Yeah, not sure why my camera is not working, but anyway, thank you for the excellent presentation. I've got one question here. Let me just read it out to you. Yep. Thanks, Lauren. Great talk. Is CIMT program offered to both ischemic and hemorrhagic stroke patients? If so, do you see difference in the effectiveness of the CIMT outcomes between the 2 groups?
That's a great question. CIMT programs can be offered to people who both experienced an ischemic and a hemorrhagic stroke. One of the great things about CIMT is that we do now have literature showing that it's an effective intervention both early in stroke recovery and also for people further on in their stroke recovery, 2, 3 or more years after their stroke. And so it is a very useful intervention. The main thing I would just point out, though, is that it's people are only eligible for the intervention if they have to have some minimal movement requirements within at least 2 of their fingers and their thumb, a little bit of active extension, and that's to demonstrate that they have to have an intact corticospinal tract in order to make improvements with the intervention. So hopefully that addresses that question.
That's great. So I've got yeah, so Peter said thanks. I've got Helen and Isabella says It's very good presentation, Lauren. And then there's another question from Helen here. Implementation research is so valuable with evidence-based intervention. Are you planning on doing another follow-up audit to look at sustainability of the gains over time? Over to you.
Thanks very much, Helen. At the moment, we hadn't planned on doing another follow-up audit. I think for us, one of the challenges has been is that we hadn't been provided with any ongoing support for some of the elements that I touched on, like continuing to provide booster training sessions or to facilitate the ongoing community of practice. So I think that there would be benefit in doing a further follow-up to see if those changes are sustained. But I would suspect that we might unfortunately see somewhat of a drop-off without those ongoing supports being in place. Thanks, Helen.
Thanks, Lauren. That was great.
While we're waiting for more questions to come, I just have one here, Lauren. I noticed the CIMT that you presented is looking at one aspect of intervention. Do you have any plan in the future, say looking at different aspects, for example, like in stroke patient, I know they sometimes have difficulty with language or difficulty with gaits or anything. So what's the plan?
Yeah, sure. Thanks for the question, Audrey. I mean, definitely the lessons that we've learned from Active Arm are very applicable to kind of any evidence-based intervention, and definitely implementation science is a growing area within stroke and stroke management, and Bola will be covering a bit more on that shortly in the next talk. But I am very excited to be involved with some colleagues from Interstate in some further work looking at other areas of implementation within other areas of upper limb practice. And I'm definitely aware of further implementation studies being conducted around aphasia management in Queensland by colleagues Kirsten Shrubsall and some of the group up there. So it's definitely a growing field and very excited to be involved in it because I think it really helps to support us delivering high quality care.
If there's no more question, we might move on then. Thank you, Lauren, for a fantastic talk. I'll introduce our second speaker today. So Dr. Bola Fasugba works as a senior research officer in the Nursing Research Institute, a collaboration between St. Vincent's Health Network, Sydney, St. Vincent's Hospital, Melbourne, and a Australian Catholic University in Canberra, I believe. She's currently involved in implementation science research project aimed at improving translation of evidence-based nurse-initiated stroke care protocols in hospitals. So you can start sharing your screen, Bola, so it's over to you.
Thanks, Audrey. And thanks everyone for coming for today's presentation. So I'll be presenting an international cross-sectional survey of the hospitals participating in the Registry of Stroke Care Quality, Rescue. So this study was a collaborative project between researchers from the Nursing Research Institute, Australian Catholic University, the Registry of Stroke Care Quality, Rescue, which sits in the Czech Republic, and also researchers from Monash University. So stroke is a leading cause of death and disability worldwide, and an important approach to improving the quality of stroke care is through the use of clinical quality registries, which allow the systematic collection and analysis of stroke patient data to assess its alignment with evidence-based practice and clinical standards. The data are then used to identify gaps in clinical practice and inform improvements in stroke care quality. So the Registry of Stroke Care Quality or Rescue is a global clinical quality registry, and it acts as a platform for the continuous monitoring, evaluation, and improvement of stroke care quality. So the registry has been used to collect data from hospitals since 2016. It started off as an initiative of the European Stroke Organization targeting Eastern European hospitals, but has since been endorsed by the World Stroke Organization and is used by quite a number of hospitals worldwide. So rescue captures performance and quality measures that allow the standardized comparison of stroke care quality internationally. And hospitals that provide data to rescue receive feedback via dashboards, which are updated daily, and also downloadable reports from the rescue website that have benchmarking at both the hospital and national levels. So I guess one of the key things about rescue is that the registry works in close collaboration with the Acute Networks Striving for Excellence in Stroke initiative, or the ANGELS initiative. And this initiative is a not-for-profit organization that is run by Boehringer, and it's composed of dedicated consultants who are referred to as ANGELS consultants. And they provide healthcare staff with support and training to undertake to implement best practices for patients at the hospital level, and also to undertake quality monitoring. So in essence, the ANGELS consultants, they act as change agents or facilitators to support clinical staff with undertaking stroke care practices. And also this, serves as an opportunity for them to undertake quality monitoring, and as well as quality improvement activities. And hospitals participating in rescue, they're considered for the quarterly ANGELS Awards. Could either be the European Stroke Organization or the World Stroke Organization ANGELS Awards. And they receive either a gold, platinum, or diamond status when they meet specific performance thresholds. And these awards are actually just to recognize their efforts in undertaking quality improvement at their hospitals. So to date, rescue is currently being used in over 80 countries, and the database has been used to capture, the registry has been used to capture data from patients, from over 490,000 patients worldwide. And this figure just shows the number of participating centers in rescue per country, just to highlight how widespread this clinical quality registry is being used globally. So it's clear that there's widespread uptake of rescue, but participating in a registry may not necessarily result in local quality improvement. And despite the widespread uptake of rescue, there's still limited knowledge of who receives feedback on rescue data beyond the staff collecting it at the hospitals. There's also limited knowledge on whether the data are being used to drive improvements in stroke care, and also regarding the educational needs of the local stroke clinicians that participate in rescue. So to address these gaps in practice, we decided to undertake this study, which aimed to determine if and how rescue data are being used to inform local quality improvement activities, and also to identify the educational needs of stroke clinicians to improve the use of data to drive practice change. So we used a cross-sectional design, and participants received a self-administered electronic survey. And all hospitals that were registered with rescue up until August 2021 were eligible for inclusion in the study. The survey participants were the rescue hospital local coordinators, which a stroke unit or stroke service staff responsible for the collection, the coordination, and the entry of data into rescue. And 1 week prior to the commencement of the survey, the rescue team sent out a recruitment email notifying participants of the pending survey. So this survey we used for this study was actually informed by 2 previous Australian surveys, which were used to collect data about quality improvements in regards to registry data use. The survey was developed in REDCap, and it was pre-tested with a panel of expert stroke clinicians. And there were minor modifications made to the survey following the pre-testing. It took approximately 20 minutes to complete the survey. So the online survey was administered over a 4.5-month period from the 14th of October 2021 to the 28th of February 2022. And non-responders were sent reminders from the rescue team via email and also phone calls. And the data from the surveys were analyzed in SPSS using descriptive statistics to describe the respondents' characteristics as well as their survey responses. And the study was approved by the Australian Catholic University Human Research Ethics Committee. So just moving on to the results. So we sent the survey via email to 1,463 hospitals, and it was completed by 358 hospitals from 55 countries, giving a response rate of 24.5%. Just looking at the respondents' characteristics, most respondents were medical doctors, with just less than 10% being nursing or allied health staff. Respondents said they had been contributing, most of them said they had been contributing to the registry for between 1 and 3 years, keeping in mind that the registry only was only open for use for hospitals to collect data in 2016. Most respondents also said that it took them between 11 and 20 minutes per patient to collect and enter data into the registry. Regarding the sources of data entered into rescue, most data were obtained from the patients, the electronic patient's medical records, the hard copy records, as well as the patient discharge summaries. So we asked respondents how often they viewed the rescue hospital dashboards. And we can see that less than 30% viewed the dashboards as and when required, monthly and weekly. We also asked respondents if and how often they downloaded the rescue quarterly reports. We can see about 35% said they downloaded the reports as and when required. About 22% said they downloaded the reports once every quarter during the deadline for the European Stroke Organization or the World Stroke Organization Angels Awards. And we can also see that there were about 21% of respondents who said that they were aware of the rescue data reports, but had never downloaded them. Regarding who receives monthly feedback about progress in stroke management based on rescue data beyond the local rescue coordinators who collect the data, you can see that just 10% of the data were actually being sent to the hospital quality units and the clinical governance teams. And about 11% of the hospital administration and executive units received any feedback about the data. So we asked respondents if they believe their involvement with rescue had led to improvements in stroke. And when we combine the results for those who strongly agreed, we can see that over half said that they believe that their hospital's involvement with rescue had led to improvements in their stroke care practice. So we also asked respondents if how rescue data influenced clinical practice. And given that we're targeting their use of the data for quality improvement initiatives, respondents said that about 60% of respondents said that they used rescue data always or often to develop quality improvement initiatives. So for those hospitals that were involved with the Angels Initiative, we also wanted to find out what activities they were working on in collaboration with the Angels. And the main two activities they were working on were the interactive e-learning modules and development of a stroke care pathway. So as mentioned previously, one of the aims of this study was to identify the educational needs of clinicians to see what they needed help with to improve their use of the data to drive quality improvement within their hospitals. And we can see that the top 3 education topics that respondents said that would be helpful to change clinical practice in their hospitals were data-driven practice change, data-driven evidence practice gap identification, and quality improvement science and methods. So while respondents said that rescue was seen as worthwhile to enhancing stroke care improvement, there's still a need to identify effective strategies to increase their use of the data to drive stroke quality improvement activities, given that only 60% were actually using the data for this purpose, which is quite suboptimal. And to help them identify effective strategies, an important place to start will be to explore in future research their perceived barriers and enablers to undertaking local data-driven quality improvement activities. There's also a need to improve the feedback of rescue data to hospital quality units, as only 10% of respondents said that feedback was sent to the hospital quality units or clinical governance teams, which is quite low. And it's important, and this just highlights the need to embed registry data use in hospital management systems. It's also important to provide staff access to quality improvement education to help develop their knowledge and capability to put quality improvement into action. As if registry data are actually to be used to inform quality improvement activities and not just to provide feedback. The staff need to actually improve their knowledge around quality improvement science. So in conclusion, rescue data are a valuable resource for hospitals to use in monitoring the quality of stroke services and identify areas for improvement. And there's a need for effective strategies to increase hospitals' adoption of quality improvement standards. And educating staff in quality improvement science may help develop their competency to improve use of the data for local quality improvement activities with subsequent improvement in stroke care. So I'd just like to thank the Rescue Scientific Committee and the hospitals that participated in this study for their contribution, and also to acknowledge the funding that was obtained for this research. Thank you.
Thank you, Bola. That's right on time. Might get you to unshare your slides, please.
Okay.
While I read the question here, we've got one question from Peter. Great talk, Bola. Just wondering why there aren't any centers participating in rescue in North America. Is it because they have their own system? If so, how is it compared to the REQQ? Thank you.
Thanks for the question. I'm not sure what REQQ stands for, but yes, North America, which I guess that comprises the United States, they do have rescue. Thanks. They do have their own registry that they tend to enter data into, so they don't use rescue. Sorry, what was the other part of the question? I'm just thinking.
So Peter just said, oh yeah, it's a title.
Oh, how is it compared to rescue? Oh, I'm not really sure, you know, what quality improvement variables are collected in their own registry as opposed to rescue. But I want to believe that because these are standardized measures, it probably will be similar. But I'm not sure if they specify that hospitals, like rescue specifies that hospitals undertake continuous quality improvement, which is the preferred approach to data entry. But I'm not really sure the specifics of the North American registry that is used.
Okay, thank you. So Isabella said great talk, Bola, and Sally had a question here which is similar to what I have in mind. She's just wondering why she just wondered why Australia's participation is low, and that's similar to my question. I noticed there's low number of responder from hospital survey. Can you elaborate on that, please, or any comments?
In terms of Australia's, we do have, I think when we look at the results by country, we do have one Australian hospital that did participate in the survey and submits data to rescue. But because Australia already has the Australian Stroke Clinical Registry, that's OSCAR, that hospitals already contribute data to. And I guess there currently isn't any system that allows the you know, the overlap of this registry so that, you know, data can easily be transferred. I think most hospitals, and also given the different regulations around data sharing, most hospitals in Australia stick with OSCAR. And I really want to believe it's more around data sharing because, you know, they're not in contact with who exactly manages rescue, even though rescue is well managed and you can't just access the data. But I guess one of the reasons why Australian hospitals hasn't taken up rescue as such is because they already have their own system in place, which is OSCAR.
Okay, sorry, go ahead.
No, in terms of, I was going to the next question about the low response rate. I can't give an exact reason, but we know that while we're undertaking the survey, one of the reasons was, the ongoing pandemic might have contributed to the low response rate. But generally speaking, the evidence shows that online surveys generally have a lower response rate as opposed to postal surveys. But given the fact that we were trying to cover a widespread geographical area, since rescue is used globally, the most effective way we could collect the data was using an online survey, not a postal survey. So unfortunately, we knew that there was a risk of having a low response rate. But in saying that, we did have data from 55 countries, which I think is relatively good.
So can I clarify, Bola? So that's worldwide, so we're talking about across the world now.
Yeah.
The majority of them, sorry, I might have missed this too in one of your
That's all
slides.
right.
The majority of them come from where? Like Europe or Asia?
So majority of the countries come from Eastern Europe, because that was where initially rescue was targeted at, but the World Stroke Organization now endorsed it. So most countries that use rescue sit in Europe and East Asia. So countries like, for example, in India, in Vietnam, yeah, they use rescue a lot. Yeah, and also some African countries do use rescue as well.
All right. Might wait a bit for if there's any more questions. I might have my last question to you, Bola. You're talking about quality improvement standard. So is that based on each local hospital, or is it standardized across the whole participating hospital?
Well, in terms of quality monitoring, which is what the data that have been collected is focused on quality monitoring. We expect that based on the data that hospitals submit to rescue or whatever registry, it doesn't even have to be a stroke registry, but the logic behind is that you submit data to a registry in terms of monitoring the care provided to patients. But the key thing isn't just ending at quality monitoring and submitting that data and receiving feedback. It's using that data to improve practice, which is the overall goal, which is where quality improvement comes into play. So depending on, it will still have a local application to it because every hospital is different. So, and the way clinicians handle things at every hospital, there's a standard, there's the standard guidelines in terms of stroke care quality. They're the national guidelines, but you expect that within the local context, because of all the different contextual factors, you expect hospitals to modify that standard to suit, their own situation or their own context. So in terms of saying whether or not it applies, it's both. I see that, we take what we've used, the data that has been submitted, and then apply to making changes locally within the hospital setting.
Fantastic. Thank you for that, Bola.
Thanks.
So if there's no more questions, so let me thank both presenters for their excellent talk today. So that's to Lauren and Bola. Thank you as well to whoever joining us for this seminar. Both who's joining virtually or in person here with me. Thank you to CVRN and thanks to Heart Foundation for their continuous support. So our next seminar, which is in August, first Monday in August, that would be convened by Dr. Monique Francois from University of Wollongong, and we will again have two excellent presenters, Dr. Angelo Sabak from Western Sydney University and Dr. Helen Parker from University of Sydney. And their theme for next month is Exercise and Nutrition, the Pillars of Cardiometabolic Health.